Medical emergencies can occur unexpectedly in any healthcare setting, including dental clinics. Knowing how to recognize and manage these situations is crucial for both patient safety and practitioner confidence. This video provides a practical overview of common medical emergencies, focusing on their salient features and step-by-step management strategies. From syncope to allergic reactions, each scenario is explained with clear guidance to help you respond effectively. We'll start by understanding the basics of emergency recognition, then move through specific conditions, highlighting prevention, intervention, and when to seek advanced medical help. Let's begin our journey into emergency preparedness, ensuring you're equipped to handle critical situations calmly and efficiently. Vasovagal syncope is the most frequent medical emergency in dental practice. It's defined as a sudden, transient loss of consciousness with spontaneous recovery, often triggered by anxiety, fear, or pain. The underlying cause is a vagus-mediated reflex bradycardia, sometimes accompanied by peripheral vasodilatation, leading to reduced blood flow to the brain. Signs include lightheadedness, dizziness, pallor, nausea, sweating, and fainting. The pulse is typically slow and feeble. Prevention focuses on stress reduction, good communication, and reassurance. If syncope occurs, position the patient supine with legs raised to improve venous return. Aromatic ammonia can stimulate respiration, and oxygen may be administered. Always monitor airway and vital signs, and be prepared to manage persistent hypotension if needed. Hyperventilation occurs when patients, often due to anxiety or fear, breathe rapidly and deeply, leading to excessive loss of carbon dioxide. This results in decreased arterial CO2, causing constriction of cerebral blood vessels and symptoms like lightheadedness, dizziness, palpitations, and tingling. The cycle can worsen as anxiety increases. Management involves reassuring the patient and encouraging slow, normal breathing. Oxygen therapy is not indicated here. Instead, patients should breathe through cupped hands or a detached oxygen mask with holes, avoiding the outdated paper bag method. Sedation may be needed in severe cases. Breaking the cycle is key to restoring normal breathing and preventing complications. Asthma attacks in dental settings can be triggered by anxiety, particulate matter, or certain drugs. Symptoms include coughing, wheezing, shortness of breath, and air hunger. Asthmatic patients should bring their inhalers and use them prophylactically. During an attack, seat the patient upright and administer oxygen. Use bronchodilator inhalers, repeating puffs as needed. If inhalers fail, IV salbutamol or IM epinephrine may be considered. Monitor vital signs and oxygen saturation, aiming for levels above 90%. Seek medical help for life-threatening signs like persistent wheezing, cyanosis, or deteriorating mental status. Hydrocortisone may prevent relapse. Allergic reactions range from mild skin symptoms to life-threatening anaphylaxis. Common allergens include antibiotics, anesthetics, and latex. Skin reactions present as itching, redness, and rash, while severe cases may involve bronchospasm or laryngeal edema. Anaphylaxis requires immediate management with antihistamines, epinephrine, and hydrocortisone. Epinephrine is the drug of choice, administered IM or IV, and should be preloaded in emergency kits. Supportive care includes airway maintenance, oxygen, and rapid saline infusion. If airway obstruction persists, cricothyrotomy may be necessary. Educate patients about allergens to prevent future incidents. Diabetic patients are prone to hypoglycemic and hyperglycemic emergencies, especially in dental clinics. Hypoglycemia is sudden and dangerous, causing confusion, headache, and possible loss of consciousness. Hyperglycemia develops slowly and rarely causes acute loss of consciousness. Hypoglycemic patients have cold, wet skin and may have high blood pressure, while hyperglycemic patients show flushed, dry skin and low blood pressure. Immediate correction of hypoglycemia involves giving glucose orally or IV dextrose for unconscious patients. Hypoglycemic emergencies require supportive care and hospital transfer. Monitoring blood glucose helps differentiate between the two. Angina presents as brief chest pain due to reduced blood supply, often triggered by stress or exercise. Myocardial infarction is caused by a clot, leading to permanent heart damage and risk of arrhythmias or cardiac arrest. Symptoms include chest pain, heaviness, shortness of breath, and pain radiating to the arm, neck, or jaw. Management aims to decrease heart oxygen demand or increase supply using supplemental oxygen and nitroglycerin. For myocardial infarction, aspirin is given and the patient is transferred to cardiology care. If cardiac arrest occurs, initiate BLS and CPR with AED. Seizures are abnormal brain electrical activity, often due to epilepsy, hypoglycemia, or hypoxia. Typical tonic-clonic seizures involve muscle contractions, loss of consciousness, and risk of injury. Never restrain movements or put objects in the patient's mouth during a seizure. Turn the patient to their side, protect the head, and monitor airway and vital signs. Oxygen can be given after the seizure. Status epilepticus requires IV diazepam to stop seizure activity. Refer patients to their neurologist for medication adjustment after the event. Drug overdose can result from excessive dosing, rapid administration, or inadvertent intravascular injection. Lidocaine toxicity presents with agitation, confusion, and possible seizures. Opioid and benzodiazepine overdoses may occur in clinics using pharmacosedation. Management of lidocaine overdose is supportive. Maintain airway, administer oxygen, and monitor vital signs. Naloxone reverses opioid toxicity, while Flumazenil is used for benzodiazepine overdose. Both have shorter durations than the drugs they reverse, so close monitoring is essential. Observe patients for at least an hour post-reversal. Choking or foreign body aspiration can occur when dental instruments or materials slip into the oropharynx. Most swallowed objects pass through the gut safely, but sharp items require urgent gastroenterology consultation. Airway obstruction is a major risk, especially in children. Mild obstruction may be relieved by coughing, but severe cases need urgent intervention. Visible objects can be removed with forceps or suction. The Heimlich maneuver and abdominal thrusts are recommended for severe airway obstruction. For infants, back slaps and chest thrusts are used. If unsuccessful, surgical airway procedures may be necessary. Cricothyrotomy is a rapid surgical procedure to secure the airway in emergencies where obstruction cannot be relieved by other means. It involves making an incision in the cricothyroid membrane and inserting a tracheostomy or endotracheal tube. Commercial kits are available and should be part of the emergency kit. The procedure is quick, requires minimal equipment, and is preferred over tracheostomy due to fewer complications. Once the airway is secured, the patient can be ventilated and stabilized before further management. Always consult a pulmonologist for removal of foreign bodies lodged in the bronchi. Hypotension, defined as systolic pressure below 90 mm Hg, can cause inadequate cerebral perfusion and loss of consciousness. Vasovagal syncope is the most common cause in dental settings, often accompanied by bradycardia. Recovery is usually achieved by positioning the patient supine with legs elevated. Persistent hypotension may require drug intervention. Atropine is useful for hypotension with bradycardia, administered IM or IV, and repeated as needed. Rapid saline infusion can increase blood pressure. Ephedrine is helpful for patients with normal heart rates, while phenylephrine is used for those with tachycardia, improving venous return and systolic pressure. Transient hypertension may occur during dental procedures due to pain or restlessness. Most cases require only a timeout to calm the patient. If symptoms like chest pain, headache, or visual disturbances accompany hypertension, drug intervention may be needed. Esmolol, a selective beta, One blocker is effective for acute events and is rapidly metabolized. Dose is titrated based on repeated blood pressure and heart rate measurements. Avoid nifedipine due to risk of excessive blood pressure lowering. Esmolol also helps manage tachycardia. Known hypertensive patients should receive their usual medication if missed. Cerebrovascular accidents, stroke, and transient ischemic attacks, TIA, are caused by interrupted blood supply to the brain. Elderly patients with uncontrolled hypertension, diabetes, or atherosclerosis are at higher risk. TIA symptoms are brief and recover within 24 hours, including slurred speech, numbness, or temporary paralysis. Stroke symptoms include altered consciousness, headache, nausea, vomiting, facial paralysis, and hemipalsy. Management requires urgent recognition and hospital transfer. While arranging transport, position the patient to prevent aspiration, maintain airway, monitor vital signs, and administer oxygen. Early intervention is crucial for favorable outcomes. Preventing medical emergencies often starts with effective stress reduction protocols. Good communication, reassurance, and creating a calm environment are essential, especially for anxious patients. Techniques such as explaining procedures, using gentle approaches, and allowing breaks can significantly reduce the risk of syncope, hyperventilation, and other stress-induced emergencies. Practitioners should be attentive to patient cues and intervene early if signs of anxiety or distress appear. These preventive measures not only enhance patient comfort but also improve overall safety during dental and medical procedures. Continuous monitoring of vital signs is a cornerstone of emergency management. Pulse oximetry, blood pressure, heart rate, and respiratory rate should be checked regularly during and after any emergency event. This allows for early detection of deterioration and guides intervention decisions. Oxygen saturation should be maintained above 90% in respiratory emergencies. In cases of drug overdose or seizure, monitoring ensures timely administration of antidotes or supportive measures. Proper documentation of vital signs is also important for ongoing patient care and communication with other healthcare providers. Airway management is critical in emergencies like anaphylaxis, choking, and seizures. Techniques include positioning the patient, suctioning, and using airway adjuncts. In severe cases, surgical procedures like cricothyrotomy may be required. Practitioners should be familiar with the equipment and steps involved in securing the airway quickly and safely. Training and practice in airway management can make a significant difference in patient outcomes during life-threatening events. Always ensure airway patency before proceeding with other interventions. Basic life support, BLS. Protocols are essential in managing cardiac arrest, severe respiratory distress, and unconsciousness. BLS includes chest compressions, airway management, and rescue breathing. Automated external defibrillators, AEDs, are used to restore normal heart rhythm in cardiac arrest. Practitioners should be trained and regularly updated in BLS techniques to ensure rapid and effective response. Early initiation of BLS can significantly improve survival rates and outcomes in emergency situations. Having a well-stocked emergency drug kit is vital for managing medical emergencies. Essential drugs include epinephrine, antihistamines, bronchodilators, glucose, naloxone, Flumazenil, and hydrocortisone. Kits should also contain airway management tools, oxygen delivery devices, and cricothyrotomy kits. Regular checks and updates ensure drugs are within expiry and equipment is functional. Practitioners should be familiar with the contents and their indications, enabling quick access during emergencies. Educating patients about their medical conditions, allergies, and emergency protocols is a key preventive strategy. Encourage patients to disclose relevant medical history, carry necessary medications, and avoid known allergens. Clear instructions before and after procedures help reduce anxiety and prevent emergencies. Awareness empowers patients to participate actively in their care and respond appropriately if an emergency arises. Prevention is always better than cure, and patient education is a cornerstone of safe practice. In summary, medical emergencies require prompt recognition, clear protocols, and effective management. From syncope and asthma to choking and drug overdose, each scenario demands specific interventions and preventive strategies. Stress reduction, monitoring, airway management, and emergency drug kits are foundational elements. Patient education and regular training ensure readiness for any crisis. By following these guidelines, healthcare professionals can safeguard patient well-being and respond confidently to emergencies. Stay prepared, stay informed, and prioritize safety in every clinical encounter.